So I want to provide you guys with an intro to interpartum fetal surveillance. So how we're monitoring the fetus while mom is on labor and birth or labor and delivery. So as we think about this conversation and think about the electronic fetal monitor, we want to recall what has it led to, the fact that we are now watching every baby throughout almost the entire labor when somebody is on labor and delivery. I think you can gather from this picture that it has increased our C-section rate so that we're up to about 1/3 of all births being cesarean sections. And we know that not all of those cesarean sections are indicated. And in a lot of national benchmarks, the goal is to decrease the national C-section rate. So the reason that electronic fetal monitoring has led to an increased C-section rate is because we have this monitoring system, and it does a really great job of telling you which baby is being perfused well and is well oxygenated, but it doesn't do the opposite. So it doesn't give us a clear picture when the strip is a category 2 or 3, that baby is severely compromised. So I had shared in class that we do a lot of C-sections where the baby comes out screaming at us. And yes, that's a great outcome because that means that baby is, going to have strong apgars if it's coming out moving and yelling. However, it begs the question of, was that cesarean section truly needed? So in thinking about that, why is it a problem to just have our C-section rate continually rising? Well, we've talked about the fact that women usually have more than one child. And that being said, we know that women with cuts to their uterus with C-sections have a risk of abnormal placental development in future pregnancies. So meaning they're at risk for that placenta accreta. This is a C-section baby just born. So in thinking about electronic fetal monitoring, we want to think about how the fetus gets oxygenated and put that in context of while mom's in labor. So this is a review, but maternal and fetal blood are not mixing. And while the woman's in labor and she's contracting, remember those spiral arteries are going to stop perfusing blood across the uterine muscle so that at the peak of a contraction, there is no blood flow happening to the baby through that umbilical vein. So the fetus has a reserve. It will be fine during that period. That's a normal process. This is showing it from another angle, showing you sort of how that diffusion of blood is happening through the endometrium, that layer of muscle on the uterine wall, and giving you an appreciation for the fact that the baby does have a reserve and will not be getting blood flow at the peak of a contraction. So we want to think about sort of how this fetal oxygenation relates to things. So we want, in order going into labor, for things to look good for that baby to be well oxygenated and well perfused during labor. Going into this process, it'd be great if there's normal blood flow. So what would be abnormal is if mom had something like preeclampsia, if mom was using cocaine, if mom was a heavy cigarette smoker. That's all going to alter how the blood is flowing just normally before she was even in labor, right? That's setting her up for less blood flow, all of those things. Does mom have a normal O2 sat? Because if she doesn't, that's also starting us below the curve in terms of fetal reserve. And then thinking about adequate exchange of nutrients through the placenta. And that's really thinking about, okay, if she's after her due date, is that placenta really calcified? Is it starting to get old? Is there something physically going on with the placenta? And then number 4 really thinks about baby's position. So there's not really much to do in this context, but to think about if the mom doesn't have a lot of amniotic fluid around the baby, there might be a lot of impingement, a lot of pressure on that umbilical cord, and that's going to alter fetal oxygenation. The other thing is there's babies born with what we call a nuchal cord, so the cord around the neck. That will factor how the baby is oxygenated. Babies can be born vaginally that way. Just sort of depends how tight that cord is. If it's loose, we can sort of get through labor okay. But if it's a really tight cord, the baby would start to show some signs of distress. And then, is there a cardiac issue with the baby underlying? Does the baby itself, that fetus, have a circulatory issue that would be affecting how it's oxygenated while it's in utero? So I want you to go through and review how the fetus regulates its heart rate. Again, how the fetus, so because we're talking about the baby in utero still. So I referred you to the page. Make sure you look over this. And thinking about the pathological influences that are going to take effect on how that fetus is oxygenated. So we've just talked about if the mom has high blood pressure. So if she's just in general hypertensive, or if she has preeclampsia, think about and write for yourself, how does that affect baby's oxygenation? Now let's think about if she is hypertonic in terms of her uterus, meaning she's contracting every minute, one contraction on top of the other. Thinking about what you know about blood flow to that fetus during contractions, how do you think that baby is presenting in labor? And then how about if there's an issue to the placenta? We're going to talk about a placenta abruption in depth, but at its basic, it's when the placenta starts to separate from the wall of the uterus while the baby is still in utero. It could be partial, it could be full. Think about if that placenta starts to detach before the baby is out, what is going to happen to that baby? Also think about it in the context of the baby having the cord around its neck, which is called a fetal nuchal cord. So jot down for yourself what you expect to be going on with the fetus's oxygenation in those situations that I just laid out. This is helping you with the placental abruption image. So you can see that with a placental abruption, there's a separation. So again, think about how that fetus will be presenting if that occurs. All right, so we've thought about the context of how this fetus is oxygenated, and then I want to just remind you how we can actually assess it, and there's a picture on the next slide. But a fetoscope is literally a stethoscope that allows us to hear the fetus's heart rate through mom's belly. The Doppler is what is used in office settings, and there's also a protocol for low-risk women in labor. It is completely fine to keep them off the electronic fetal monitoring and do a Doppler protocol where we're listening to that fetal heart rate at prescribed times, where when she gets all the way up to pushing for labor, she is going to be monitored with every contraction with that Doppler. So it is a really clear protocol, hospital to hospital, of how to use the Doppler. And then the third, the electronic fetal monitoring, which is what most of you will see in the hospital settings, can be done either continuously, where the woman is in bed attached to the monitor in the room, or can be done telemetry-wise, and I'll show you a picture of that as well. That's sort of the walkie-talkie version, which I like better, so she can get up and walk around. And it includes looking at the baby's heart rate, and then I have here written the TOCO transducer, meaning we're going to monitor her uterine contractions as well. Because if you think about this, we're going to be using that contraction to look at what the fetal heart rate above it is doing while she's contracting. That tells us how that baby, that fetus is oxygenated and how it's tolerating labor. So the image number 1 on the top is the fetoscope, and then you've got your Doppler on the bottom. And then this is commonly what most of you have seen in the hospital as the electronic fetal monitoring. We've got a belt up here for contractions and a belt down here for fetal heart rate, okay? Again, think about why this belt for contractions is up higher. You might want to recall which part of the uterus is actively contracting. And this is my push for the telemetry monitor. In this case, the partner is wearing it for her, but she can wear this over her shoulder as well. But this device is sending a signal to the nurse's station, to the computer, so that you're still charting what the fetal heart rate is. So say this is a woman who ruptured her fluid and there was meconium, yet she still wants to get up and walk around. We know that meconium puts her at higher risk for the baby having signs of distress in labor. So we want to monitor her, but we don't want to confine her to bed. So here's one way that we can achieve both monitoring and her walking around. All right, so let's recall our normal fetal heart rate. So normal fetal heart rate, we're going to have our 110 to 160. So you want to take each of those extremes, and that's your, less than 110 is going to be bradycardia, greater than 160 is going to be your tachycardia. In order to say that the fetus is those two categories, is either of those two categories, the tracing has to remain in those fetal heart rate categories for at least 10 minutes. Variability you'll see when we talk about in class is the beat to beat. So if I circle here, the line is really jagged for the fetal heart rate, and that's a good thing. We don't ever want it to be a static line. That would be a really ominous sign and a sign of fetal distress. So variability is the beat to beat change in the fetal heart rate. An acceleration is going to be an increase in the fetal heart rate, and a deceleration would be the exact opposite, a decrease in the fetal heart rate. So I will go through variability in class. I want to flip through this so you can make sure that you're familiar. You can see that this is that static line I'm talking about, really bad. Minimal. Talk about the reasons for that. Moderate, I want you to for now to highlight this is what we hope and expect to see. Moderate variability, and I'll teach you how to read and determine that it is or is not moderate variability. And marked is the final category of variability. So accelerations are the increase, and we'll talk about those in class. I want you to get familiar just for right now. While you look at strips, we always start on the bottom and look at the contractions. So from the start of one to the start of the next, and we count. This one's about 90 seconds apart here. These two, I should say. And then we look up top and see, well, what's the fetus doing during these contractions? Well, it looks like it's responding quite well, and we'll pick this apart in class for sure. Again, more accelerations. And then we're going to talk about decelerations. I'm going to let you flip through the rest of these on your own pace, just to sort of get familiar with them, and I promise you by the end of class you'll feel very comfortable, and I'll teach you step by step how to determine what type of decels, if any, she is having in her fetal heart rate, in the fetal heart rate strip.